Hi everyone, we might get started. Welcome to our webinar this evening. This is the second of our series of 2 webinars and we're focusing on rehabilitation for dementia, and specifically our topics tonight revolve around comorbidities, models of care, work, exercise and play. And this, these presentations stemmed from some work that a number of the authors have done and our presenters who were authors. Associate Lee Fay Lowe and I put together all this fantastic work and brought it together in a book, which I had up on the screen share a while ago. So the book is Rehabilitation for Dementia, and it's just been released, and you can either order it online or you can access it by asking one of your local libraries to purchase the book. We've got a great program tonight. I just want to start by acknowledging that we're here in the spirit of reconciliation, and we acknowledge the traditional custodians of the land throughout Australia and their connections to land, sea and community. We pay our respect to elders past and present, and we extend that respect to all Aboriginal and Torres Strait Islander people today. We will have each presenter speaking for approximately 10 minutes. And then at the end of the presentations, after those 5 presentations, we'll have an opportunity for some discussion. If you have questions as the presentations are happening, please post them in the comments box or the chat box, and we'll be looking at those throughout the presentation, and we'll be able to ask some of those on your behalf at the end of the session. So welcome everybody, and I'd like to start by introducing our first presenter. Professor Sue Kurrle is a geriatrician. She works in hospital and community settings. She's the Curran Chair in Healthcare of Older People in the Faculty of Medicine at the University of Sydney and at Hornsby Ku-ring-gai Hospital in Northern Sydney. Welcome, Sue.
Thanks, Kate. I'll share my screen and hopefully this will work. So, hi everyone. Thanks for being here. I'll start my timer for the 10 minutes. So yeah, physical comorbidities of dementia. Look, I just want to start with a brief story. This is a patient of mine, 78-year-old lady, lived with her husband in Northern Sydney, 7-year history now of Alzheimer's disease, on donepezil, now significantly cognitively impaired. And I just want to look back. 5 years ago, she began to lose weight despite eating really well. She's lost about 7 kilos in the last 5 years. 4 years ago, she started getting visual problems. She had trouble negotiating steps, seeing the sort of the roots in a footpath. She had a few trips and falls due to that. And often her husband would comment she couldn't see the knife or the fork on the table or a cup when she was eating or drinking. 3 years ago, she developed urinary incontinence, and her husband has managed that with sort of regular toileting and pads. 2 years ago, she developed episodes where her right leg twitched and then gave way, often leading to falls, and then followed by a short period of confusion. This was occurring 2 to 3 times a month. And then finally, unfortunately, 6 months ago, she had the leg twitching, she had a fall, hip fracture with surgery, but she is now in high care as she wasn't able to learn to walk again. Now, she is a snapshot of the physical things that happen in dementia rather than the cognitive or perhaps the psychological things. So we know that a number of conditions occur much more commonly in people with dementia than in people without dementia. And whilst we put a lot of emphasis on the cognitive symptoms, on memory and thinking, and on the behavioural and psychological symptoms, we don't often look at those physical conditions that are seen more often in dementia. So a comorbidity, for the purposes of my talk, is a condition or disease that coexists with another condition and has a probable pathological link to it. So I'm just going to talk through those comorbidities that we've found to be much more common, and what we can do about them. Now, falls, i.e. inadvertently coming to rest on the ground or other lower level, that's the definition, are much more common in people with dementia, at least twice that of the normal population. Fractures are 3 times as common. And so with a hip fracture, you're 3 times as likely to have a hip fracture as someone without dementia, but more importantly, you're 3 times as likely to die in the first 6 months. Why do people with dementia fall more often? Look, it could be the visual problems we'll talk about in a minute. Problems with walking and balance, impulsivity, poor executive function and planning, and lots of drugs which can cause falls. There aren't any interventions specifically which can prevent falls in people with dementia. There have been lots of studies, and there's maybe multifactorial interventions, but we're not sure which one of the interventions stops falls. We know that using physical restraints worsens falls. So the recommendations are definitely consider strength and balance training. It works for most people to stop falls. Think about walking aids if people need them. Look at their medications. Prescribe vitamin D if they're vitamin D deficient. Vitamin D is still really effective. If they've got visual problems, cataracts, treat them. Look at environmental problems, maybe consider hip protectors. Now, this is an important one, epilepsy, and certainly my patient that I told you the story of had this. And this is what a lot of people aren't aware of, that between 5 and 10% of people with dementia will have a seizure, at least one, often more, during the course of their disease. And it's basically a 6-fold increase in seizures in people with dementia, as opposed to the normal older population without. So I think the big thing is be aware. These are not TIAs, they are actually seizures, and consider an anti-epilepsy medication. Malnutrition and weight loss. It was described by Alois Alzheimer in his second patient, actually, Johann Dieter. And we know that people with dementia lose, on average, a bit over 5 kilos during the course of their disease. It's something to do with dysregulation of energy. And people lose up to 10% of their body weight. A few people will gain weight, but most people lose. And what's really interesting is that it appears that the weight loss can start to occur up to 20 years before the development of memory problems and cognitive problems. So always check someone's weight when you're seeing someone with dementia. Use protein and calorie supplements between meals, not instead. Offer finger foods, favourite foods. Keep people well hydrated, plenty of liquids, and exercise regularly. And you'll find exercise will come up again and again. Delirium, we know, occurs much, much more often in people with dementia. If you've got dementia, you're at least 5 times as likely to develop delirium if you become unwell, or you go into hospital, or you have an operation, or your drug treatment changes. And we know that 2/3 of cases of delirium occur in people with dementia, and the other third are probably developing it. We know there's lots and lots of causes, and probably post-operative infection, hypoxia, and medications are the big ones. And the recommendations are always screen for delirium. Look for it. Don't blame it on dementia if someone's behaviour changes. Look for the cause. There's always or usually an underlying cause. Keep orientated and exercising. There's that word again. Avoid physical restraints, and certainly try not to use medications to treat it. Frailty, and this is an interesting one. There is a link between frailty and dementia. Frailty is an age-associated decline in function. We know that frailty is a risk factor for dementia, and dementia is a risk factor for frailty. And they probably share underlying causative mechanisms around particularly inflammation. What are the recommendations? Physical exercise, again, including resistance training, and good nutrition. Don't forget oral disease. This is an interesting one. I certainly wasn't aware of initially. Poor oral health is more common in people with dementia compared with the same age population, and it occurs before the diagnosis of dementia. This is not bad teeth because people aren't they forget to clean their teeth. This happens before that. There's increased plaques and cavities, fewer natural teeth, and it's thought that chronic inflammation is the likely link. Your teeth are pretty close to the brain. The inflammation can easily pass up through the cribriform plate into the brain. So it's recommendations are around integrating oral health care into care from the beginning, twice daily brushing, chlorhexidine mouthwashes, and see the dentist regularly. There's no excuse not to, particularly when the dentists will come in trucks quite often to residential care facilities rather than having to take a person out. Visual dysfunction, previously known as the visual variant of Alzheimer's disease, is also quite common but not well known. Changes in visual acuity, so you don't see as clearly, and contrast sensitivity. You don't see the edges of things. And also visual field defects, blank spots in the field of vision, colour vision and spatial localization. So you can't tell where something is on a table. So there's blurred vision, lots of issues with depth perception, and this is why driving is a real issue in these people. And visual hallucinations are often linked with impaired visual acuity. So the recommendations are very much be aware that they can have visual problems, review by the optometrist or ophthalmologist early in the disease, and make sure older people can wear their spectacles. Sleep dysfunction is very common. We know that age-related changes in sleep occurring in most older people anyway, but in dementia it's added to. The day-night cycle, the rhythm, is disrupted because the body clock center in the brain loses cells. There's also more vivid dreams. The so-called rapid eye movement sleep disorder occurs much more commonly in people with dementia. So the important thing is adequate exposure to bright light during the day, exercise, there's that word again, avoid daytime napping, sleep hygiene, so don't have coffee just before you go to bed, a warm room but not too warm. We say use sedatives with caution, and possibly melatonin helps reset the day-night rhythm. And finally, urinary incontinence. We know that age-related changes happen in people, obviously, as they get older. It's the prostate in men, it's the pelvic floor in women, and more medications, often diuretics. But add to that, with dementia, the inability to interpret that you've got a full bladder, you don't know how to get to the toilet, you don't know how to get your clothes down, and you end up with urinary incontinence. And so it's really important, the recommendations to assess and treat reversible causes like infection or maybe drugs, is the person on lots of furosemide, and regular voiding, so toilet timing or prompted voiding, and don't forget wonderful pull-up pads. So I guess just to say there's a lot of conditions associated with dementia that are often unrecognised, and I think it's really important for somebody's quality of life and quality of care that they're identified and managed appropriately. Thank you.